institution that has always run with an objective of providing the best possible pharmaceutical education. And for it, the college has a very strong infrastructure which comprises of not only highly knowledgeable faculty and facility which enables students to gain contemporary education. Al-Amin College is constantly seeking to upgrade the quality of its education and actively participates in research to remain on the cutting edge. The college, through its continuous upgradation programs, had become the Continuous Education Center. A new knowledge pertaining to the pharma field is generated on a regular basis. We at Al-Amin have a vision of better individuals make better societies make better tomorrow, and a better tomorrow definitely makes a better world. Our mission is a grooming arena for better individuals and pharmacists. Today, in this difficult situation of the pandemic, we are trying to provide quality education to our pharmacy faculty and students through various webinar series and international webinars to educate our pharmacy faculty and students. In this regard, we had hosted a webinar series shortly, which had lectures from various departments. And 2 days back, we had an international webinar also. Today, we have come back with another exciting international webinar to equip our pharmacy students and faculty on the topic Pharmacist-Directed Medication Management Services, presented by our respected and elite resource person, Mrs. Geeta Pradeep. I welcome you, ma'am.
Thank you.
I'm honored to welcome our respected principal, ma'am, who is also the Dean, Pharmacy, RGHS, Dr. Shobha Rani Hiramat, ma'am. We welcome you, ma'am. I would request ma'am to say a few words on this occasion.
Thank you, Tanushree. So at the outset, I wish good evening, Geeta, and good afternoon to all the participants who have joined in, both the faculty and the students from not only our institution, but I heard that about 20 institutions participants have joined in. So a warm welcome to all of you. And I'm very pleased to have Mrs. Geeta Pradeep on board with us today to deliver a talk on the topic Pharmacist-Directed Medication Management in Australia. All of us in the hospital doing PharmD, all of us know that the disease management and the medication management are very important aspects of patient care. Particularly, medication management is a responsibility of the pharmacist. And Madam Geeta will be throwing light on this medication management, which is really a very useful topic for all the PharmD faculty as well as the students. And Geeta has been a part of our team in our Department of Pharmacy Practice from 2001 to 2008, when we established the department at Victoria Hospital, Bangalore, and she has contributed significantly to the growth of our department. And in 2008, she moved to Australia, and then she's been teaching in various universities of Australia. And presently, I heard that she has taken sabbatical to complete her thesis, and which is again on the medication management of type 2 diabetes medication, if I remember right. And it's wonderful to have you back, Geeta, with us to address our students again. So once again, on behalf of Al-Amin College of Pharmacy, your college, your own college, and on my personal behalf, I welcome you heartily for this webinar. And then I'm sure, confident that you all will be benefited from the knowledge that you're going to be imparting, and practical tips also for the medication management. Thank you.
All right.
Thank you, ma'am. Thank you, ma'am. Now, one request to the participants: kindly mute yourselves, switch off your videos also. And if you have any doubts or queries, please put it on the chat box. Geeta ma'am will be answering it once she has finished with her lecture. So over to you, Vidya, for formally introducing our guest speaker of the day, Dr. Vidya. Over to you, Dr. Vidya.
Thank you, Tanushree. Good afternoon, one and all. This is Dr. Vidya from Department of Pharmacy Practice. I'm so happy to introduce our own Mrs. Geeta Pradeep, ma'am. So to introduce a few words with ma'am, she is a clinical pharmacist educated in India, worked as a clinical pharmacy lecturer at our own Al-Amin College of Pharmacy, Bangalore for about 7 years. In 2008, she moved to Charles Sturt University in Orange, Australia, and has been teaching at RMIT University and at the University of New England until early this year. Currently, ma'am is working on her PhD thesis. Her research evaluates the impact of a GP and a pharmacist collaborative medicines management services for type 2 diabetes patients. Mrs. Geeta ma'am is a pharmacy honors supervisor, and her research projects are usually in the area of pharmacist professional service. She has been trained in the provision of pharmaceutical care practice at the University of Minnesota by Linda Strand. Pharmaceutical care and professional pharmacy services are her passion. So over to you, Geeta ma'am, for this wonderful webinar.
Thank you. Thank you, one and all. And welcome to all the students. Thanks for tuning in. I was just telling ma'am that I haven't had around 80 or 90 participants at any time in Australia. Maximum number of students that I think I've had is around 60 or 65 across 2 different campuses. So anyway, it's good to be able to, I think, be able to actually talk to students in India. It's a pity that I'm not able to see you and not able to do this in person, but it's a very good opportunity that I really like to be able to help out in any way to actually, I think, increase the knowledge transfer, and basically think about what sort of things we could sort of try out as far as pharmacy practice space is concerned in India. So with that in mind, when ma'am sort of suggested that, Geeta, would you like to give a webinar? I thought this might be the right moment to maybe talk about medication management. I think as far as clinical pharmacy services in India go, we are doing quite a lot. So I'm hoping that this is going to actually create some sort of an interest to take the next step and to think about what small things we can include in practice while we take the next step towards introducing medication management services. So what I'm going to do is, okay, let me see whether this slides are going to move. Yes, okay, good. So the whole point, my objective at this webinar is basically to give you an idea, a snapshot, because the topic of medication management services is really vast. It's quite huge. There are quite a number of different services offered at different levels, and offered by pharmacists with different levels of credentialing or accreditation. So what I'm trying to do is give you a very quick snapshot of how things occur here in Australia. So if I need to do that, I think first thing I need to do is give you a bit of an idea about the country as such, about healthcare scenario here. What is the healthcare system set up, and where pharmacy basically fits in? What's the role of pharmacy services in all of this? And then we can talk, and then that'll give you a better perspective, I think, when I go into medication management services. So Australia, I'm just giving you a very quick idea about the country. We all know, island continent, it's the 6th largest country in the world. It's got a very small population, which is a very interesting thing if you look at it there. 26 million. Not even as populous as Karnataka's. Karnataka's got 68.8 million people. So gives you an idea. And I think one of the things about Australia is that it's always been called, the nickname of Australia is Lucky Country. And one of the reasons why it's called that is because, again, low population, and a huge number of, I think, mineral, metal deposits, etc., which actually makes it possible for the government to ensure that there are very high standards in education access, in all spheres of socioeconomic fields, and therefore also in terms of health. Okay, very high, one of the countries with a very high life expectancy, 82 years. I just checked the other day, in India, the life expectancy is 69 years. So again, it helps you actually put things into perspective when you're able to sort of compare, I suppose, the stats of each of these countries. In Australia, there's a birth every minute. In India, I believe it's around 34 births every minute, which is actually low because the birth rate is coming down in India. and 1 death every 3 minutes in Australia. 10, I think 10 deaths every minute or so in India is the stats that I was able to come across. So I think one of the main things, and one reason I think that Australia is able to maybe perform so well in so many areas as such, is because of the high level of international migration. That is what has shaped the demography of this country. That's what's shaped, I guess, the amount of diversity. You know, we always talk about India being a very diverse country with huge different type of populations, languages, etc. Australia is similar to that, except for the fact that we are talking about a melting pot of different cultures and countries here. So, and that is an interesting thing, because I think many of you might be thinking about, you know, where do we go from here after pharmacy? Might be thinking of looking at developed nations such as Australia to maybe come and practice, etc. So hopefully this webinar will give you a bit of an idea around that as well. Okay, so going forward to healthcare setup or healthcare scenario in Australia. As I said, in the earlier slide, we talked, I actually talked about life expectancy being one of the highest in the world. 82 years is quite a ripe old age for people to be living. And that in many ways is now sort of shaping the healthcare problems that you find in the Australian healthcare scenario. It's very complex, very, very multifaceted, but because of the smaller population, among many other reasons, a small population has made it possible to ensure that services are quite regimented, quite compartmentalized, quite, you know, well designed. And so two main, I guess, the main things that the healthcare scenario in Australia depends on is access to affordable medicines, access to affordable healthcare or medical care, if you'd like to call it that. So this actually comes about by two main, you can say, pillars of healthcare scenario, which is the Medicare system, the Universal Healthcare Scheme, which basically means that every Australian can avail of subsidized medical care in hospitals, whether public or private, as well as for testing, for MRI scans, etc. So the government's got that system in place. There is also the pharmaceutical benefit scheme, which as pharmacists is a main driver for the entire pharmacy profession, because the pharmaceutical benefit schemes makes sure or ensures that every Australian has access to subsidized medicine. So the cost of medicines is reduced for all Australians. This does come with certain criteria, which is usually based on your economic capacity. So depending on, I guess, your earnings, etc., you would be able to, you know, you might be able to get majority of your medications for management of your conditions at a very low rate. When I say low rate, you might be paying just $6 for a medication, which is what, $30 for a 1 month supply. That is the level of difference that you actually can think of in terms of PBS subsidized medications. This entire healthcare scenario basically rests on national medicines policy, which makes sure that there is a very, there is a very stringent pharmaceutical industrial system in place to ensure that only quality medications are allowed to be brought into Australia. All medications that are marketed in Australia are actually tested, made sure that they are right for all Australians to be used within Australia. And then and only then do these medications actually get approval to be sold in the Australian market. This, of course, results in a little bit of a disparity, because you might find that certain medications which are available in the US or in the UK, anti-cancer drugs, for example, a very good example, the latest immunoglobulin medications, that sort of thing, it might take a few years to actually get into Australia, because it is, one, the cost is a limiting factor, and secondly, because they've got a very strong system of actually vetting medications before these medications are approved for use within the Australian market. So generally, the government, as I said, the government actually takes care of a lot of the healthcare costs for the common man, up to 68% and more. So gives you a bit of an idea of, I guess, the regimented sort of service that the healthcare scenario has in this country, right? So going on to our profession, where is pharmacy actually fitting into all of this? As in most countries, 3 areas of practice in Australia as well: community pharmacy or retail pharmacy, hospital pharmacy, and the pharmaceutical industry. We have around, I think, 35,000 registered pharmacists as of this month, not this month, June 2020, the last stats. And a majority of them are female, so 62.7%. I like to think that's one of the reasons why pharmacy is such an honored profession in Australia. That's just me. So majority of the people, most of the registered pharmacists, I mean, some say 65%, some say as much as 70 to 80%, work within the retail sector. And so a lot of, say, the medication management services that the government funds, there's a lot of focus for these services to be provided at an adequate level within primary care or from the confines of the community pharmacy. There's only 20% of registered pharmacists working in hospital pharmacy, and the remainder are either in academia, like me. They're independent consultants, because you've got independent accredited pharmacists who work not in a particular setting, but basically work by themselves. Again, main function is provision of medication management services. And of course, the pharmaceutical industry, government agencies, etc. The pharmaceutical industry in Australia, it is developed to an extent that can actually address the needs within the country. And that's all that they're really bothered about. And that's one of the reasons why majority of, I guess, registered pharmacists prefer to actually practice either in the community or the hospital sector. There's one point of difference in terms of education between pharmacists in the industry and pharmacists in practice. So normal undergraduate BPharm, Bachelor of Pharmacy, with or without honors, is the minimum educational qualification required for any student to basically start their internship journey or start their registration journey to get a registration to practice. Most of the pharmacists or pharmacy professionals working in the pharmaceutical industry have usually done either an undergraduate degree in pharmaceutical sciences, which focuses more on, say, manufacture, formulation, those aspects. But that pharmaceutical sciences degree is not eligible for registration to practice. So that's, I think, one difference, which again maybe diversifies the way the profession goes compared to practice and industry in Australia. I've also given you an idea of the number of community pharmacies. So this, 34,000 people, pharmacists, are actually working in over 6,000 community pharmacies all over the country. Around 1,350 hospitals. Not all hospitals have hospital pharmacy departments. And that's, I guess, one of the main, one drawback of the healthcare scenario is that with increasing cost of health, with increasing cost that's involved in provision of, say, subsidized healthcare, one of the things that's happened is that the cost has become too much. And because the cost has become too much, there's been a move for cutting cost by moving certain departments from rural areas to urban areas. And pharmacy happens to be one little casualty there, where there isn't enough, it's considered that there aren't enough funds to be able to fund at least one pharmacist in every hospital in the country. So again, this depends on hospital size, number of beds, et cetera, et cetera. Okay, so before we actually get into medication management, I just wanted to talk about how the profession of pharmacy is viewed and what practice of pharmacy basically means in the Australian scenario. Now, this particular slide set actually has a very big definition. That's what, in Australian circles, that is what practice as a pharmacist means. I just thought I just put that there for you guys to actually have a read of. But basically what it says is that you don't need to be involved in direct patient care to be considered to be a pharmacist. For example, I'm involved, I'm not practicing, I'm not registered to practice. I am basically what is known as an academic pharmacist, because I'm using my expertise, my knowledge of medicines, my skills to basically try and train tomorrow's pharmacists. So that's considered to be part of pharmacy practice as well. Okay, so it's not always to do with patient care, even though majority of registered pharmacists are in some way or the other involved in patient care. So any aspect of your profession where you're using your medication knowledge, your skills of medicines and poisons to positively affect health outcomes for patients, for customers, if it's in a retail setting, for patients, if it's in a hospital setting, to try and ensure that they are getting the best possible outcome from their medicines. The medicines are appropriate, individualized for them. That's practice of pharmacy. That's one aspect. The second aspect, to which in many ways profit in community pharmacy is tied, is dispensing. And I think in most of the world, even to this day, the profit, or the income for a community pharmacy basically comes from dispensing services, which is very much true for Australia as well. So preparing, storing medication, so cold chain management, vaccines, how they need to be stored, your dangerous drugs medication, so S4D schedule as they're called, opioid medications. So all of these, custody, making sure that they are stored under lock and cupboard as legal principles require. Preparation, dispensing, provision of medicines together with medicines, medical devices, so your asthma inhalers, sleep apnea devices, all of this falls within the purview of pharmacy. And these are all the different functions or roles that community pharmacists find themselves within the retail sector. Providing advice and health, not only in terms of face-to-face to a patient, but also public health. So in terms of disease screening, and we'll come to that when we talk a little bit about medication management as well, screening for diseases, providing healthcare education, being available in the public health space. So the community pharmacy is considered to be, it is the most easily accessible primary, first port of call for most people in Australia. It's very difficult to get in to see doctors. There's waiting, you've got to decide on a time, you've got to be available. A pharmacy, nothing doing. You can just walk into a pharmacy. You may need to wait for a couple of minutes, but you can rest assured that you will be able to talk to a pharmacist, and they will be able to give you some advice on how you can manage whether it's a minor ailment or whether it could be the start of something a little bit more serious. Okay, so this slide just gives you an idea to show how all of this, of the practice of pharmacy, the conditions for practice of pharmacy is actually entrenched in the legal principles. So this shows a hierarchy that actually guides the practice of pharmacy. One thing that I'd like to point out here, code of ethics is very important. In fact, that's the first thing that pharmacy students actually get introduced to when they come into first. It's very important for them to be aware of what the code of ethics are. And as they actually get through second year, third year, fourth year, etc., they're actually assessed on different aspects of code of ethics, which brings me to the next important thing, which is known as the competency standards. So in the pharmacy practice in Australia is based on a set of competency standards. It is a national set of competency standards, which basically means that every single registered pharmacist in this country has to work to these standards, has to be able to prove that they are able to demonstrate the services based on these competency standards. Okay, and this is a very important thing, because this starts right from the point when you are a student and moves right up to the point when you finish your internship, start your professional practice, and continues as part of your maintaining your CPD, your continuing professional development requirements every year before renewing your registration. So just to give you a little bit more idea around that, This picture that shows a lock and key model actually shows the importance of the competency standards in every aspect of a pharmacist's life, whether you're a student from Australia or whether you're an overseas educated pharmacist. If you want to actually consider, if you want to actually think about starting your registration process, you need to be aware of the competency standards. I've just given you the competency standards are quite a big document. I have a link that I'm happy to provide that gives you a full, complete details of what the competency standards are. Basically, there are 5 main domains of competency standard. Each domain is then further subcategorized into different specific skill sets. And the whole point, I guess, when we are actually teaching pharmacy students in universities, one of the main things that we are meant to do is actually assess students against these competency standards as they progress through their degree. So that at the time when they actually finish their degree, they are at what you could potentially call them as a beginner pharmacist. They're ready to get their provisional registration to start their internship practice. And they have to be able to prove, or they have to be able to show evidence that they can provide services or they can demonstrate their capability based on these competency standards. And that continues throughout. For as long as you practice as a pharmacist, whether you're, it's 5 years, 10 years, 20 years, whatever. Okay, so next we go on to how pharmacy services are provided in different settings. So I thought it would be a good idea to give you a bit of an overview about how the community pharmacy and hospital pharmacy services are administered or how they are managed, so that then you will be able to understand that when you actually say medication management, it's really actually an umbrella term. And honestly speaking, I'm sure that most of you, whoever's done pharmacy practice or doing PharmD, has heard of the term of pharmaceutical care. Basically, Australia likes to be a little unique in the way they name their services and the way they do things. Medication management services is, in my opinion, another term for pharmaceutical care. So it's basically provision of pharmaceutical care, but targeted in a way that is structured, documented, so that you can provide evidence of the service you are giving. And based on that evidence provided, you are reimbursed for that service by the government. Okay, and so you'll see more of this. I'll be talking more of this as I talk a little bit more in detail about the various medication management services. So looking at the community pharmacy service, as I said, the major amount, most of the income in a community pharmacy comes from the dispensing model. So in many ways, that even today, community pharmacy or retail pharmacy in Australia is very much dispensing model oriented, which basically means if you need to make a profit, in your community pharmacy, if you need to make the business work, you have got to be able to manage dispensing well. But then this becomes a bit of an ethical dilemma, because on the one hand, you've got your business needs, because you have got to pay your pharmacy employees. You've got to be able to manage stock. You've got to be able to manage the premises. You've got to pay rent for the premises that you're for your pharmacy premises, et cetera, et cetera. But then you're being told to actually provide professional services, which means you're taking away pharmacists from that all-important dispensing role, which is going to bring in the money. And that's one of the reasons why the government basically decided that if we want to bring in medication management services, we have got to think about how we can reimburse pharmacies, reimburse pharmacists for using their medication knowledge skills to provide these services to the patients. Okay, so that is there's still a lot of issues around that. Politically, there are always issues around any new service that comes into play. So that's happening here as well. But the government has agreed, the government is actually making a very good effort into reimbursing medication management services to pharmacists, some to the pharmacies themselves, and to actually develop this more in the coming years. So when you talk about dispensing, I mean, if you look at it from an Indian point of view, I'm hoping that this might actually be undergoing change now, but I'm not sure. When I was actually, when I was a student, when I was actually working in a community pharmacy, the whole point of dispensing is somebody would come in with a script. You get a script, you look at the medication, you pick up the medication, put it into a pack, give it to them. That's it. End of the transaction. That's not what dispensing means in Australia, because you're being paid by the government for every PBS script. Script, in other words, prescription, is otherwise very colloquially known as script. So for every PBS script that you dispense, you're being paid by the government. And so the government doesn't want you to just taking something off the shelf, sticking some labels on it and giving it, doesn't make it dispensing in its full sense. So dispensing, as far as we are concerned here, involves two things. You've got a physical aspect, which is basically identifying what's on the script, picking out the right medication, ensuring that it is the right medication, right dose, etc. Checking for problems, putting on the labels, giving it. That's the dispensing aspect, the physical aspect. But before you actually go ahead and give it to the patient, there's also a deeper cognitive level or cognitive skill that you have to apply. And that is a legal obligation of all pharmacists. Now, one thing which I forgot to mention, which is important, is that in Australia, a pharmacy can only be owned, can only be opened, can only be operated by a registered pharmacist. You can't have any business person cannot open a pharmacy. It is not legally allowed. Only pharmacists can actually run pharmacies, start pharmacies, either by themselves or as a chain pharmacy or as a banner group, whatever. So that is that in many ways, again, creates, and that's one of the reasons why you've got a very set number of pharmacies. There are also something known as the location rules. If there are certain rules which ensure that you don't have 10 pharmacies in one block of the street, you are actually spacing out pharmacies in a way that ensures that people who are coming to that locality can actually access a pharmacy within a set space, within a set area, within a set distance. So that's called the location rules. And so as a result of that, you don't have pharmacies sort of cropping up in every nook and corner. It takes time. You need to have a pharmacist or a number of pharmacists in place. You need to have a lot of approval signed off before you can go ahead and open a retail pharmacy. Okay, so I'm not going into those aspects of it, but all of those aspects actually shape the profession and the way it is, the way medication management services are provided by the profession today in Australia today. So as I was talking about the cognitive responsibility, so the cognitive responsibility is the legal responsibility, your legal obligation as a pharmacist to make sure that you're auditing the prescription. So auditing of the prescription is in two ways. The first thing is ensuring that it is a legal script able to be dispensed. That is checking that all the necessary information that is there, that should be there on the prescription, is definitely there on the prescription. Now, another thing about prescriptions in Australia, you don't have, you don't have a number of different types of prescriptions. Different doctors have their own prescriptions, different hospitals, you don't have all of that. You have, most of your prescriptions are computerized. So they're all computerized PBS prescriptions, and there are 5 different types of prescriptions. That's it for the whole country. You still have a few doctors who are possibly working in rural and remote areas who do use handwritten prescriptions, but more and more the reliance is on PBS computerized scripts. Okay. Similarly, you've got the electronic medication record that has just been started to roll out. You've got electronic prescriptions, which have come in this year and which have been a godsend with the COVID pandemic happening, because you don't need to go to the doctor's office to actually get your script. It is sent to the pharmacy via electronic transmission. You can just go and pick up your medications there. And a lot of pharmacies are actually just doing deliveries now. You don't have a lot of services happening within pharmacies. So there is that aspect as well. So that's what I mean by cognitive responsibility. It's not as simple as you need to check, make sure that the script is fine to be dispensed legally. All the I's have been dotted and the T's have been crossed. And then you go ahead and do the physical process of, checking that it's the right medication. You probably would talk to the patient or the consumer who's actually come in with the script, check whether it's for them, whether they've actually used it before, make sure that the medication is right for them. Do they know what they're taking it for? Have they taken it before, et cetera, et cetera. And then you go ahead, get the medication ready, label it correctly, bring it out, dispense it to the customer, give a CMI or a consumer medicines information leaflet that they can use, and actually talk to them, counsel them on how to actually use that medicine. Now, having said that, what I'm saying is the ideal situation. There are a lot of pharmacies that don't actually don't go through all of these processes in the right way that they should. But this is what you are expected to do as a pharmacist. And that's what the physical and cognitive responsibility of dispensing a prescription basically means. So as I said, the community pharmacy is also what's known as a healthcare destination, in the sense it's responsible for screening of conditions. So diabetes screening, screening for cholesterol, screening for blood pressure, screening for asthma, sleep apnea, mental health, all of these conditions. The primary screening usually most often can happen within a pharmacy. Health promotion activities, breast cancer, osteoporosis, again, diabetes, etc., smoking cessation. So all of these are services that are provided to the general public, to the local demographic or local consumer population by community pharmacies in that area. Okay, management of minor ailments, vaccination services, all of these are roles, are activities that community pharmacists are involved in. Now we go on to something that a lot of you, those of you doing pharmacy practice and PharmD, will be a little bit more familiar, I'm thinking, which is the hospital pharmacy services. So the hospital pharmacy services, the entire role. So all of these things that we discussed in the context of a community pharmacy is happening within the hospital pharmacy as well, except that it's happening probably to a slightly higher level of provision, higher degree of service. And this is mainly because a hospital is a place where you have people with acute issues admitted. And so they need a higher level of care to make sure that the medications are ready for them, so are appropriate for them. So some of the services that you find in as part of the clinical pharmacy services or as part of the clinical pharmacy medication management services are MedRec, or medication reconciliation. And we'll talk about what that actually means in the next couple of slides. Managing MRPs. So I think you may have heard of the term drug-related problems. DRPs, a very common term that's used when you speak of pharmaceutical care in the US and Canada and places like that. MRP is medication or medicines related problem, same as a DRP, but in an Australian context. Okay, medication chart reviews. Medication chart reviews can happen at any point in the hospital, right from admission to discharge, and on-ward rounds, etc. Dispensing and compounding as necessary, of course, that is always an important aspect of pharmacy. Counseling, and of course, DUE, drug use evaluation services, stewardship, so antibiotic stewardship programs, cardiovascular, what was that? Vancomycin stewardship programs. There are specific antibiotic programs which are provided by certain hospitals. So all of those medication services also come under the purview of hospital pharmacy services. So these are clinical services which can influence patient care. Other than that, you've got services which are provided, which are external to clinical, but have an indirect impact on clinical service to a patient, which is basically in terms of educating or training or precepting, say, intern students, pharmacy students who are on placement from universities, et cetera, et cetera. Provision of medicines information, which is something that I'm sure most of you students are definitely aware of. And of course, inventory, management of stock, management of inventory, making sure that your drugs and therapeutics committee, your hospital formulary, getting stock based on the hospital formulary, etc. Those quality assurance procedures as well. And of course, function in clinical trials as well. So clinical trial pharmacist is another role that a lot of hospital pharmacists find themselves involved in. Okay, so so far I've given you an idea of how healthcare is set up in Australia, where pharmacy actually fits into this whole picture of healthcare. We've talked about the different sort of services provided from a community pharmacy perspective, from a hospital pharmacy perspective. So now let's start talking about medication management services. All right. As far as, we don't have a set definition as such, but very clearly speaking, if you look at the last point that I've put there, any professional service that you as a pharmacist are providing using your knowledge of medicines, your knowledge of poisons, your knowledge of services to patients, where it can influence a patient's medication taking behavior, can help to individualize medication needs for a patient, thereby ensuring that they get a better outcome from their medications. That's considered to be a medication management service. Okay, there are different names for this based on specific services which the government pays for in the community pharmacy setting or in the hospital setting. The government doesn't really need to pay for the services in the hospital setting, because in the hospital setting, it comes under the entire hospital budget, so to speak. So it's in the community that the government has made a specific effort to reimburse these services when pharmacists provide them appropriately. Okay, so you have different terms, you have different names for these services based on where they are placed, community or hospital, whether they are based on, say, an interaction or a management service provided starting from a prescription that comes into the pharmacy, or whether it is a more holistic approach to managing a patient. So all the medicines, all the conditions that a patient has, whether it's about managing that aspect for them. Okay, and so I've given you a couple of examples of services specifically targeted towards prescription and specifically targeted towards patient-centered care. Okay, so let's talk about hospital services first, and then we'll go on to the community services. All right, so as I said, in the hospital, now see, all of these medication management services, so to speak, they have all basically what is being provided in the community pharmacies today, or as independent pharmacy consultants today. All of this is based on initial research which has been done within the hospital pharmacy setting. So these services have, they have been part and parcel of hospital pharmacy practice for a number of years. Okay. It's only now that they're getting a little bit of an importance. Pharmacists have been doing this all through. But now the profession is asking that they be recognized for that cognitive service that they're doing, and which is what the government is trying to do in terms of reimbursing them for specific services. Okay. All right. So these clinical pharmacy services, again, in one of the things in Australia, what you'll find in healthcare is that there's a lot of documentation process. They have tried as much as possible to standardize processes so that if, say, for example, from one state, from Melbourne, from Victoria, which is where I am now, I go to Sydney, which is another state, I can still expect a comparable level of practice in a hospital or in a community pharmacy there. And for that, they've actually got a number of different standards of practice, like you would have heard of standard treatment guidelines. Similar, you've got standard treatment guidelines as well, but these are standards of practice for professions. And nearly all the healthcare professions have them. So for hospital pharmacies, the standards of practice for clinical pharmacy services is the most important document. And I've put a link there that you can actually be able to have a look at. So I'm happy to provide these slides. I'll provide these slides to ma'am after this, and they can circulate it among the students depending on what they think is suitable. Okay, so where does medication management service happens? Usually in a hospital. In most hospitals, a hospital pharmacist will be one of the first professionals, one of the first practitioners that a patient sees on admission. They will also see the hospital pharmacists as they get transferred through the different areas or different, so, from emergency to, say, general medicine, or from emergency to surgery or whatever. So as they go through transitions of care, and they will also probably see a pharmacist at discharge. In those hospitals where you have hospital pharmacy services. Okay, so when when that happens, because you're actually seeing the pharmacist at these different junctures, there are certain services which are provided at each of these junctures, basically to sort of track the changes which happens from admission to a particular ward, from movement from that ward to another ward, which is known as transition of care, to discharge. And then once the patient is actually discharged home, when they go into the community, back into their community to see their doctors. So at each of these critical points, there's usually a medication reconciliation, which is a medication management service provided by the hospital pharmacist. Okay, so again, so to provide a medication reconciliation, you use certain formats or certain forms. That's what is coming up in the next couple of slides. And that's called the best possible medication history, or the BPMH as it's called. Okay, so what is a medication reconciliation? Basically, it is a structured process. And this is one word that you will see with every medication management service that I'm talking about. It is a structured, regimented process which has ways of being documented to actually prove the benefit of that service to the community at large. So this is a standardized process. And basically what I'm meant to do as a hospital pharmacist while doing a medication reconciliation is reconcile a patient's medication. So what does that actually mean? So that means that I need to, so I've got a patient, okay, so somebody, John Doe has been admitted, he was admitted last night, 6:30 p.m., has had, say, a transient ischemic attack, admitted into the emergency. He's recovered fairly well, but some medications have started at that point in the evening. So in the evening, there was no pharmacy service. And as a result, I'm the first pharmacist on duty the next day, 8 o'clock in the morning, I'm coming to see John. He's in the emergency department. He's in the emergency as yet. He's under observation. They're planning to either discharge him based on what the doctor says when they come on rounds, or to move him to another ward, maybe the general medicine ward, as the day moves on. So as part of the medication reconciliation, my job is to basically to talk to John and find out about what are the different medications. I'll have his hospital medication chart there to look at what has been done for him in the past, say, 12 hours or so since the previous day evening. And then I will actually be talking to John about what are the medications he takes on a general basis. Does he have diabetes? Does he have hypertension? What sort of medications does he take? And this means not just the prescribed medications, vitamins, mineral supplements, herbal supplements, all of these medications. Get an idea. I'll get John's account, that is the patient's account, and that's eliciting this information is known as getting the best possible medication history. Right? So we get that, we talk to John, we get that, patient interview happens, we get all that information. And then basically what I do is I check or verify this information with, say, medications on record at John's medical center. So that is with John's general practitioner or GP and with John's community pharmacy. Based on the information I get, I make sure that the medications that started for John at the hospital, I need to make sure that John's wife hasn't bought his medications from home and isn't giving that to John in the middle. So I need to make sure that he's only using, say, for example, hospital medications. So that's what medication reconciliation is all about. And that's how you reconcile the medicines. Basically assure that medicines are not being repeated, medications are verified for accuracy, and you are getting a complete picture of John's medications. And that then gets entered into a medication management plan. So this medication management plan, right from emergency, will move with John as he moves through the different departments in the hospital and as he's discharged. Based on this medication management plan, when he's going to be discharged, I'll sit down, discuss with the doctor. The doctor will give the discharge medication orders. I'll check the discharge medication orders, and then basically sit and talk to John and say that, okay, fine, these are the medications the doctor wants you to take now, right? Be aware you have some of this sitting at home. So these are the names of those medications. For the next 2 weeks, because the doctors actually prescribe medications at the hospital for the next 2 weeks, continue to take the medications I'm giving to you today from the hospital. The medications at home, let them be there. Do not take them. At the end of 2 weeks, make sure that you go and see your GP. Information about what has happened in the hospital, it's my responsibility to send it to the GP so that they have an account. And so I think someone hasn't muted their microphone.
Yes, ma'am.
Yeah, please mute your microphones, please.
Anyway, so I'll continue.
Sorry, ma'am, for the
No,
inconvenience.
that's all right. It's very common. I sometimes forget to mute it myself, so that's okay. So basically, that's what a medication reconciliation is. Now, why I'm taking all this time to sort of explain it is because you will see similarities when I actually talk about home medicines review when we look at services provided in the community pharmacy setting. So keep this in mind. This is at the back of your head, and you will see the same sort of skills coming up again in a different service, in a differently named service in another slide. Okay, so these are, I'm hoping that this will work. These are the links to the actual medication management plan. Let me see, I'm not sure whether I'll be able to show it to you entirely. Maybe I shouldn't. I'll leave this in the slide. So in your own time, you can actually have a look at that. So what these links are, they actually show you the National Inpatient Medication Chart, the National Medication Management Plan. So as I said, these are all standardized formats for use in the entire country. So all the hospitals use the same National Inpatient Medication Chart. They use the same hospital medication chart. They use the same medication management plan. So, if for whatever reason, if John needs to be taken to a hospital in another state, they will still be able to get an idea of what's actually happened with him because the documentation is fairly similar. And there's advantages in that when you talk about medication management services. Okay, so these again are links of the medication charts. So this brings me to the next question. Now, when I've been talking about, very structured processes, and it's very common for us to think that, in a country where something is so well structured, chances are there are not too many issues anyway. But that's not really the case. As you have good processes, you also have fails and gaps in those processes, and that's happening here as well. So this slide is just to give you an extent, despite all these medication management services, a high level of documented community pharmacy and hospital pharmacy services, you still have a lot of medication misadventures in Australia. And this is to give you an idea of the statistics around that. Okay, so 250,000 hospital admissions every year just because of medicines, either because people haven't been taking medicines properly, they haven't taken their medicines, so adherence issues, either intentional or non-intentional. It could be because of increase or very high doses, so adverse drug reactions. It could be because of very low subtherapeutic response, as a result of which the patient ends up in hospital. So in some way or the other, around 250,000 hospital admissions can be linked back to medicine use, which is not a good thing. And 50% of this is actually preventable. This is another driver as to why they want pharmacists involved, to ensure that we can actually bring that 50 further down. Okay, 1 in 5 people, a lot of people in hospital, like I said, not all hospitals have hospital pharmacies. Therefore, not all hospitals have the facilities or have a pharmacist, a hospital pharmacist involved, or a clinical pharmacy service involved in the hospital. And as a result, in many small hospitals, especially in rural areas, you will find nurses actually conducting the discharge counseling or the discharge review, or there's no discharge review happening at all. They get a script that actually gives them the discharge medications, and they get discharged out of the hospital and away they go. So studies have shown that 3 in 5 of hospital discharge issues are because of the fact that pharmacists are not involved. There are also studies that have sort of compared pharmacists, nurses, as well as medical residents in the way they conduct medication reconciliation process and how they conduct best possible medication history. That the study has actually shown that of the 3 professionals, A pharmacist is the one that does a very thorough job when they actually conduct a best possible medication history for a medication reconciliation service. So again, shows that there are specific skills that the pharmacists and their knowledge about medicines that the pharmacist can actually bring in, which are going to help with ensuring that you can try and bring down the level of medication misadventure in the country. Okay, so continuing with the Australian context, what medication management means. So I think I've already said this in a couple of slides or all through the previous slides. The whole point of ensuring what in Australia, medication management service or programs, the main aim is to ensure appropriate use of medicines. In Australian term, quality use of medicines, QUM is what it's called. And the whole point of this is to ensure that we don't have medication, or we're able to reduce medication misadventures and preventable hospital admissions, etc. And that is what the government is intent on supporting. So as I said before, in a couple of slides before, I did talk about the increasing cost of healthcare. And as a result of that increasing cost, now, one of the things that's happened all through the history is that healthcare has always been what is known as episodic, in the sense you have an issue, you go to the doctor. You might have type 2 diabetes, unless and otherwise, say, for example, you have a callus on your foot, which becomes a major wound that just doesn't heal, causes foot ulcer problems, you go to the doctor. But until then, you're probably not going to go to the doctor. And as a result of that, every time when we go to the doctor, we have an urgent issue that we want managed. And most of the times, in the 15 minutes to at the most half an hour, most doctors' consultation, 5 to 10 minutes if it's a short consultation, 15 to half an hour if it's a longer consultation, they are able to address only the acute problems. They are not able to actually check about how the person's actually going, or whether this acute problem has had, there's a deep-rooted reason for this acute problem, which is from another chronic condition the person's suffering. So this doesn't get taken care of. And that's one of the reasons why, again, medication management services and pharmacists have been brought in to ensure that we are able to provide continuity of care as far as medicines management goes. Okay. Someone's actually raised their hand. Can I get you guys to actually monitor that?
Sure, ma'am, we'll do it.
Yeah, okay, fine. And then we can maybe when I actually respond to the questions, we can discuss all of that.
Yeah, sure, ma'am.
Yeah, okay, all right. So that's the whole process. That's the whole context of medication management services as far as from an Australian point of view. As I said before, two approaches, and we're going to look at those approaches now, whether it's because of what are the services, what MMS services are provided that actually start from the receipt of a prescription, and what are the more holistic medication management services available. Okay, so prescription-focused medication management services, as the name indicates, start with a prescription. So a very simple example that I can give you is recommending a generic product. So I've got someone who's come in with a script for Crestor. I'm hoping that you guys know Crestor, brand name for rosuvastatin, and it's one of the biggest sellers in Australia. Okay, it is available on the PBS, so it is available as a PBS subsidized medicine, but there are also generic versions of rosuvastatin available, right? And there is a price difference. So, if I need to dispense, if someone is very intent, if they come in with a script for Crestor, I have the opportunity to actually go ahead and dispense Crestor because that's what the doctors actually ask them to take, which means that they can actually they can get Crestor, but they would have to pay sometimes $1.50, sometimes up to $3. Again, this depends upon which particular brand it is and what the brand premium is. They have to pay a brand premium for that. While on the other hand, the generic, they probably will be paying $3 or $4 less. And generic substitution is where I go and talk to the patient and say, see, I know the doctors actually prescribed Crestor for you, but we do have an alternative, which might be a more cost-effective option for you. Would you like to consider that? So then the patient can say, nope, I just want exactly what my doctors asked me to, go ahead and dispense that. If they say, okay, but is that different from the one that the doctor told me, gives you an opportunity to explain that it is in no way different. It is exactly the same thing, except that it is just a slightly costly, like slightly less costly version, because the brand name carries a premium on it. And then the patient can take a decision on what they want. So that's a very simple example of prescription-focused medication management service. Similarly, medication counseling, which is something that we do all the time. Counseling about the condition that the medication is meant to treat. That's a medication management service, prescription-focused. Right? Monitoring of warfarin in the community pharmacy, monitoring of clozapine, making sure that they have their blood test before you go ahead and dispense the next clozapine. So clozapine is something that's very highly monitored in Australia because of the very large amount of toxicity associated with it. So there's a lot of monitoring, and so pharmacists are very much involved in assessing the prescribing appropriateness of clozapine, whether they've done the blood test, whether they've got the results before they go ahead and dispense the next dose. Okay, so these are all simple examples. Then you've got medication management services, which are meant to actually help people adhere to their medications. So elderly people, people who may have, say, Alzheimer's, dementia, who don't have carers to actually manage their medications for them, people who have really complex medication regimens, so number of comorbidities, number of medications that they're taking, they might find it difficult to actually remember what medication they should take in the morning, what they should take in the afternoon, etc. There are also people who find it difficult, basically, they've got osteoarthritis, find it very difficult to pop the pill from the blister pack. So for those sort of people, you have what's known as dose administration aids. Okay, and we'll be coming to dose administration aids, I think, here. I'll go back to clinical intervention since I started talking about this now. So basically what happens in a dose administration aid is that it's that packet there, that picture that you can see. That's an example of a dose administration aid. And this is what pharmacists do in the pharmacy. They actually prepare the dose administration aid for a particular person. So it will have the name, the details of the person. It will have all the medications individually packed based on the time and the day that they have to take. So, I don't have to break my head about whether I'm supposed to take metformin 500 milligrams in the morning and then metformin, say, sustained release 1,000 milligrams at night. I don't have to think about that. I just take the medications based on what is actually packed there. Okay. And so there are some medications that you can't pack. So those that don't have an appropriate, say, stability profile, you will not be able to pack. So they have to be managed differently. But most medications, this is a very good service, that actually is, again, we've got an aging population here in Australia. So this is something that's used quite a lot, and a lot of pharmacies provide this service to their patients. Okay. So coming back to the other one, that is clinical intervention service. So clinical intervention, again, you will find this clinical intervention happening at every step of a medication management service, whether it's prescription focused or patient focused. So basically in clinical intervention, it's called so because it is an intervention you're providing when you get a script in the pharmacy and you're providing it from a community or a retail pharmacy setting. Basically, what you're doing is you are identifying an issue with the medication that has been prescribed. It could be that the patient's taking the wrong, the bottle has been labeled as one, but the medication inside is totally different. And the patient's coming in because they've got some side effects. It is not, this is something that new symptoms that they've been on this medication for so many years, they haven't had an issue, but suddenly they got this medication and they've got a side effect because of that. It might be a labeling error that you're finding. It might be that the medication hasn't, the wrong medication has been prescribed. It might be that the person's also seeing another specialist, and so he's taking the same medication, 2 different brands. So that's called a medication related problem. So it could be a problem in compliance, it could be a problem in dosing, it could be an adverse reaction, it could be a problem with knowledge, a lack of knowledge. So as a pharmacist, you're able to identify this and resolve that. So identifying and resolving medication-related problems that actually result in a modification of the therapy that has been prescribed is known as a clinical intervention. So you document it, and these documented claims are submitted to the government, and the pharmacy gets paid for those clinical interventions. Okay. I'm going to give you an example. So before we go on to the example, this document here is what is used to classify medication-related problems. Okay. So if you look at that, problem in drug selection, problem in underuse or overuse of a medication that's been prescribed, compliance issues, undertreatment, where a medication hasn't been prescribed. They should be getting a medication, they should be prescribed a medication for prevention of a disease. Say, for example, a person who's got osteoarthritis on, say, celecoxib, could potentially, and he's got a history, the person's got a history of peptic ulcer disease. So he needs to be put on gastroprotection, but the doctor hasn't done that. Right, so that's an example of, say, where a problem has been undertreated or not treated. Monitoring requirements, education, effects that you can't classify under any of the others, and adverse effects. Now, this is the way that here we in Australia basically document medication-related problems. There are a couple of different ways of classifying medication-related problems out there. Most of them, from the North American context, there are a couple of different ways of doing that. This is what we're using in Australia, and this is what is being used for reimbursable services. Okay, so let's look at the example that's come in where I can provide a clinical intervention. So, a mother's come in with a script for Cefalexin, 125 milligrams QID, and that's for their, say, daughter weighing 30 kilograms, right? So I look at the script first audit, the script is valid, it is a legal prescription, I can go ahead and start getting it ready. Talk to the mother, understand why the medication's been prescribed, realize that this is the first time that the child's actually getting this medication. Okay, fine. Say that I'll get your medication ready. Go and check the dose to make sure that the dose is right. When I check the dose, I realize that the dose is actually low. That child, based on 30 kilograms body weight, should be getting around 187.5 milligrams. And this is based on a child's dose as given in, let me show you that. This is the AMH. This is sort of the Australian MIMS or SIMS or whatever it is that you guys are used to using. This is a Bible for any pharmacist. You have online, you have hard copy versions of this. That is always your go-to. Any issues, this is where you look at. Because it has an account of all the medications which are available in the Australian market today. And it's updated every year. Okay, the online version is updated every quarter, I think. So that's how dynamic the AMH is. So look in the AMH, I realize, okay, there's an issue with the dose here. The medication-related problem that I've identified is that the dose is too low, right? I go back, I talk to the mom, and I say that there is an issue with the medication. Are you happy for me to contact, Dr. So-and-so, whoever the prescriber is, so that I can just confirm that the dose, I can just confirm the dose that's on the script? The mother says, yes, go ahead and talk. I go and call the doctor up, tell the doctor that this is what has happened. I have identified this issue. I'm just wondering whether the dose needs to be changed. So the doctor would definitely ask, okay, why? Because I've got a reference that actually says that it needs to be based on 30 kilograms. This is the dose that the child should be getting. The doctor will then ask the doctor whether you're okay. He's happy to send across a new prescription. So rather than get the mother to go back and get the prescription by hand, I just ask, would you mind faxing that new script through? Doctor faxes the script, I go get the medication ready, dispense, counsel, the mother is off. Okay, so that is a clinical intervention. And then I document it, saying that I've identified O2. So you can look in this here, O2 is prescribed dose too low. And I've recommended a change, a dose increase, as well as a referral to the prescriber. I've done the referral for the mother, but I've still recommended that. So then I go on to the recommendations category and find out which it is. Dose increase, R1. I've referred to prescriber, that's R9. Yes, so that I document that. That goes to the claims. When it is time to go to the claims, the pharmacy gets reimbursed for this clinical intervention. Plus the fact that tomorrow, say for some reason, if the mother comes back with any query, and I'm not on duty, it's somebody else who's on duty, they can address the issue because they've got a documented information about what happened when I initially prescribed the medication to them. Okay, hope that gives you an idea of how clinical intervention actually works. Okay, this link here, I will allow you to read it. This is something that actually happened. I think it was 2 years ago, and which actually resulted in a court case. So a patient was prescribed methotrexate. You all must be knowing methotrexate, anti-metabolite used for cancer treatment, used for treatment of resistant psoriasis, used for treatment of rheumatoid arthritis, etc. So a patient was prescribed methotrexate. Methotrexate is usually prescribed weekly 1 dose because it's a highly, highly toxic drug. This patient was prescribed the normal dose, but every day, take once daily, 25 milligrams. Pharmacist had a doubt, contacted the doctor. The doctor was very adamant, said, no, I've checked it up. I want you to dispense it like this. The pharmacist at that point did not have the confidence to go against the doctor, went ahead and dispensed the medication. The patient died on the 5th day. There was a criminal case, was charged. Both the doctor and the pharmacist were found to be guilty of causing the death of that person. Okay, and that account, that it's just that story that you can read that gives you an indication of how important the role of medication management services, clinical intervention, etc. is. Okay, so moving on, just to put things into perspective, that clinical intervention as such, it can result in a number of different other medication management, small little medication management services. So it's all linked. None of these services work in a silo. They're all linked to many other services. Okay, we've already talked about dose administration aids. And then the next service that I'd like to talk a little bit about is stage supply. So stage supply is a structured process where I've got a prescription for a 1-month supply of diazepam, okay, for a person, for someone who's got, say, mental health issues. And the doctor is very much worried about suicide ideation, suicide tendency in that patient. And so the doctor says, I'm giving you, say, a 6-month supply, but I'm going to suggest that the pharmacy provides it to you as a stage supply of, say, every 3 days. Basically, that means that the person brings in the script. I have a 1 month or a 1 month supply of diazepam for that person, but that I don't actually dispense the entire medication volume to the person. It's stored in the pharmacy, and based on the patient just needs to come in every 3 days or whatever installment the doctor has decided on. I dispense the medication based on that. So that's called a stage supply. I'm supplying a medication prescribed, not in the whole amount, but in a periodic installment, because the doctor has requested that. It can be the doctor, it can be the patient themselves saying that I don't have a confidence that I can actually manage this. Please, can I get it dispensed to me in stages, right? So this is done on basis of a written agreement. So the doctor signs off, patient signs off, pharmacist signs off. So that's what a stage supply is. And the rest of the medication remains earmarked for that patient in the pharmacy. The pharmacy will store it and give from that volume of medication, dispense it every 3 days to that patient. So that's what a stage supply is. Okay. So now we go on to the most interesting bit. And I find it interesting because this is what my research has been about, is patient-centered medication management service. So in this, you don't consider any one medication or 2 or 3 medications. You actually consider the patient as a whole. So you look at the patient's entire experience, conditions, what medications that they're taking, how they're actually, what their medication taking behavior is. Are they having adherence issues? All of that is looked at holistically, and a plan is agreed upon with the patient. Okay, so that's what a patient-centered medication management service is. It involves shared decision-making. Okay, sometimes the highest level of medication management service, which is known as a comprehensive medication review, home medicine review, for example, that can only be provided by pharmacists with extra credentials. So they've got to undergo a whole extra level of training, and only those accredited pharmacists can provide that highest level of medication management services. But other medication services, such as meds check, etc., just a quick check of medicines in the pharmacy, can be provided by any pharmacist. Okay. So it involves shared decision making. Basically, it is a face-to-face consultation with with the consumer or with the patient. The patient brings in all their medications. You ask them to bring in all their medications. You schedule an appointment time for them, a time when you're not going to be involved with any dispensing activity in the pharmacy. You have set that time apart for a non-dispensing role, which is a medication management service, right? So you sit down, you conduct you interview the patient, you talk to the patient, you find out what issues they're having with all their medications. You ensure that they know about those medications, check their level of awareness, level of knowledge about what they're using the medication for, and help to actually bridge any gaps there are. So that's in a small level, that's what's known as a meds check. That's a smaller level of medication, patient-centered medication management service offered in a community pharmacy setting. And a comprehensive medication management or a medicine review is what is offered either in a GP practice or in a patient's home by the accredited pharmacist. Okay. So the steps are fairly similar. It is just that there are different levels of complexity in which the steps are provided. Different levels of detail come into the interaction and cause different result outcomes from the medication management service. Okay, so you can imagine this comprehensive medication management review services was started in Australia in 2001. And there has been a lot of problems since then because prescribers do not want, there's been very, very little uptake amongst GP practitioners. They actually saw it as, pharmacists don't have the training required to actually speak about this or to talk to patients, etc. So we do not agree with this, etc., etc. But now there are a lot of doctors who actually, again, research studies have helped to a great extent, have actually shown the positive, the beneficial effects, not only to the patient, but to the doctors as well, because it actually saves them a lot of time and makes their job a little easier. And so a lot more doctors, especially the younger ones, are more on board with medication management services. They're just so happy that they've got a pharmacist that they can blame for the whole thing. So that's it. It doesn't mean a medication management service does not mean that you replace the prescriber service. It only means that you're adding one more level of care, which is a pharmacist level care, so that the pharmacist can check that the medicines actually make sense for that patient. Okay, so when you talk about medication review services or patient-centered ones, you don't just look at the prescription medications. You look at everything the patient is taking. So this would mean that you might get a little bit of the information from the GP practice. The patient's probably seeing an endocrinologist. They've prescribed some other medications. The patient's seeing somebody else. They've prescribed some other medications. And as a result, when you conduct a visit to the patient's home and look at the huge number of medications that are there with the patient and sort out each by each, remove the ones that are really not required, agree on a plan that the patient is happy to start on, things or say small little medication changes which are within your scope. Say, for example, if a patient is using duplication of medications, you can tell them to stop. They don't need to take both, they only need to take one. If the patient, one very common HMR or intervention that you actually find is the use of proton pump inhibitors, PPIs. I think a class of medicines that's been abused more than used appropriately. So you find that there are a lot of people in Australia who are actually on pantoprazole, omeprazole, whatever, for years on end. And there are a lot of issues that can actually occur as a result of continuous long-term use of these medications. So as a pharmacist, it's within your scope to actually introduce a step-down approach, taper the dose a little bit, and then start a continuity service so that later on, say 2 weeks from now, you can taper the dose still further. So that's within your scope. Certain things may not be within your scope, in the sense the doctor has to say yes to it. So you talk to the patient that these are the things that I'm thinking of, but it does depend on whether, Dr. Joe thinks that that's the best option for you. So that means that, this might be, this is something that the doctor is going to take a call on at your next meeting with the doctor. So all of this information goes into a medication management report or a plan, inform to the doctor, speak to the doctor about it so that the doctor can actually consider the recommendations and initiate what the doctor thinks is appropriate for the patient. Okay, so that's what you mean by it's a shared decision making. It's not about the doctor doing one thing on his own and then I go and do something else. It is a shared decision making where the patient, the doctor, the pharmacist, we're all on the same page, or at least we try to be on the same page. Okay, so Meds Check service. So Meds Check service is a lower level review service, which usually happens within a community pharmacy. Again, this is a reimbursed service. Can happen for any person who is having multiple comorbidities on more than 5 medications, has maybe been into the hospital because of certain issues and has a lot of medications as a result of that they're just not very sure of. These are the people who can actually avail of a Meds Check service, right? And the idea is to actually, as I said, the idea is more educational, more increasing of the patient's awareness, helping them manage that condition a lot better is the main focus of a Meds Check service. Okay, one important thing to think about, remember when I was talking about Meds Check or Med Review service, I did say that it has to be separate from dispensing. You cannot be providing a Meds Check service for the first, say, 15 minutes or so, because usual Meds Check service take around, say, half an hour to 45 minutes, or maybe even more than that. So you're in the middle of a Meds Check service, and then the pharmacy technician comes in and says, this thing needs to be checked, or that medication needs to be looked at. No, that is not a proper Meds Check. It has to be separated from the dispensing process, separated from the dispensing floor, and you have to be able to focus entirely on this non-dispensing service or a Meds Check that you're providing. Okay. These are the forms which are used for Meds Checks. So the next is the main comprehensive medication management review, the highest level of medication management service. It's called an HMR, or a home medicines review, if the patient's GP has asked me to provide that for the patient, and I go to the patient's home. I make a time with the patient, go to the patient's home, check all the medicines that the patient's got in the home, and then provide an action plan for that. It may be something that I actually provide to an aged care setting. In such a case, it's called an RMMR, a residential medication management review. So I might actually be going into an aged care facility and looking at, say, maybe 10 patients or 20 patients on one day, and then go back the next day or whatever. So that is the way in which that service is provided. So, and this is a service that's only provided by consultant pharmacists. So consultant pharmacists are pharmacists who have a higher level of training, and they have been accredited. They're called accredited pharmacist, accredited HMR pharmacist. So they've been accredited to provide a home medicines review or a comprehensive medication management review by the Australian Association of Consultant Pharmacy. That's the AACP, which is what most Australian pharmacists go for. Or it can also be from the Board of Pharmacy Specialties from the US. So in geriatric pharmacotherapy and ambulatory care pharmacy, two specific aspects of that, you can do a credentialing in that, and that gives you the ability to go ahead and provide medication management services in Australia as well. Okay, it can also be provided by a new pharmacy role, which is called the primary care pharmacist. This is what my research has actually looked at, integrating a primary care pharmacist into a GP practice to help with managing medicines for type 2 diabetes better. So now the government's actually accepted that. And I think from last year onwards, primary care pharmacists are slowly becoming a mainstay feature of medical practices or general medicine clinics, medical practices in Australia. Okay, so this is a diagram that actually shows you the entire review of the cycle of care. And I think the most important thing that I'd like to, this is all going through what I've been speaking till now. This is a cycle. It is not something that actually ends by just one medication review. For some patients, just one medication review will work. But for some patients, you need to have that continuity of care and have additional follow-ups. Okay, so the government basically pays now, the government's actually started paying for 2 follow-up HMRs after the initial one. And I think provided it's done by the same pharmacist, because that again helps in ensuring a continuity of care. Okay, the different steps involved. Again, this is exactly what I've told now. I've just put that into a infographic for you because it would make a little bit more sense when you actually go through it. But this is all that I've actually talked to now. Referral criteria. So, while it's great for everyone to be able to get an HMR, it's just not practically possible. And so the government's actually introduced referral criteria. So what are the referral criteria? Basically, people who have multiple chronic comorbidities, who are on polypharmacy, who have, in spite of taking medications, appropriate medications, have a poor clinical response. So possibly it could be an adherence issue. So these are the major referral criteria, which makes a patient eligible for a home medicines review or a medicines review. And this is something that's undertaken. So basically the doctor is going to say, I really think that you can benefit from a pharmacist coming in and talking to you about your medicines. Are you happy for someone to come visit you at home? Patient says yes, a referral goes to the pharmacist. The pharmacist makes an appointment, goes, does the HMR, comes back, provides the report to the GP, right? So this chart actually gives you a step-by-step process which will help you to approach medication, interviewing the patient to discuss medication-related problems, okay? So the only reason I put this here is because I thought it might be really helpful for students because it can give them pointers on how to maybe tailor questions when you start counseling about medications, or when you start interviewing the patient, whether it is a medication counseling or whether you're trying to elicit information for a best possible medication history, etc. Okay, so what are the aims? What are the questions that you need to think? What are the most essential medicines for this person? Are, the patient's on 10 different medications. Are therapeutic objectives actually being achieved by 10 medications? Or can we actually achieve the same objectives with just 5? Right? So those sort of things are questions, these are all prompts, I suppose, that you could use when you're initiating a conversation with a patient, as well as when you're initiating discussions with doctors as well, to rationalize or justify your medication recommendations. Another thing that actually helps a lot of pharmacists to carry out medication management services are a number of different indicator tools, which are something, you can use these tools, apply it to the medicines list for that patient to consider whether the medicines are right for the patient or not, to look at prescribing appropriateness for those medicines. Okay, so these are tools which are used to rate or identify inappropriate prescribing of medicines, and therefore give you an idea of how to resolve those issues. Okay, the start stop. I don't know, many of you students might have actually seen these, may have used some of this for projects, etc. Again, these are really good tools to actually try out in hospitals, where if you're on your placement, if you're thinking of your MPharm projects, etc. A couple of these might be, really good tools to actually use. The one that I've used personally, which I feel I know a little bit about, is the MAI, the Medication Appropriateness Index. Very time consuming to actually use that, because you have got to apply the criteria to each and every medication that the patient is using. And if the patients, and some of the patients that I've got in my research, as part of my research, they have up to 12 medications, and it takes at least 15 minutes, if not more, to do a complete MAI index for one medication. So gives you an idea of the complexity involved. Okay, situations when follow-up may be required. So I think this is self-explanatory. If I've had a review with a patient, But then for other reasons, I've had a review, talked to the patient about diabetes medications, etc. The patient also happens to be an asthmatic, severe asthma attack, admitted to the hospital, nothing to do with the diabetes, but admitted to the hospital, changes in medications. And so, a follow-up might, the patient's had an acute hospital event, it might be advisable to actually go ahead and conduct a follow-up. Okay, so those are the different conditions where a follow-up makes sense for a home medicine. You don't need to have a follow-up every time. You need to have a follow-up for prescribed, I suppose, for justified reasons. And these are examples of those reasons. Okay, I'm ending the near of that. This is just to show you where each of these medication management services sit in the whole scheme of under the whole umbrella of medication management services. Very simply, starting with your dispensing, stage supply, clinical interventions come here as well, in between dispensing and stage supply. It's not shown in this chart, but this is where clinical interventions come. Dose administration aids, meds check, diabetes meds check, and of course your comprehensive medication management reviews. Okay, I think, and this is to give you an idea of the cost of the payment, because I've all through the slides I've been talking about the government reimburses, This gives you an idea of how the government actually reimburses. Okay, I'd like to draw attention to the HMR, which is, a good amount, $222 for every patient that you review, and you can do up to 30 patients in a month. Okay, so this is a space. HMR is a space where a lot of accredited pharmacists have actually set up their own sort of a business, where all they do is actually just provide home medicine reviews. Okay, challenges. I've talked about the challenges all along, issues with provision of these services. A lot of people, general public, really don't know that they can ask these services of pharmacists. So that's one major issue. Low GP uptake, turf wars. So doctors having problems thinking that pharmacists are coming in to take over their territory, etc. The time involved in actually providing these services is a major issue. And of course, difference in access of service, depending on where in Australia you are. You don't have a lot of accredited pharmacists to provide these services in rural areas. And that's a big drawback, because a lot of people in rural areas really have major problems, and they've got to travel up to 200, 300 Ks to the next nearest hospital. So huge distances to cover. So that's a major problem that needs to be addressed. And finally, a summary. So basically, I think what I've been trying to tell you is that medication management services, we are going to have problems with medications for as long as people have illnesses, for as long as you've got humankind around. Okay, the condition is going to be even more compound because you've got an aging population, more and more people becoming older, more and more conditions that need to be managed. So the medication management service is an appropriate solution to managing or to trying to help reduce this medication related issues, morbidity, mortality, etc. And pharmacists are the right person to do it. You've got a doctor is trained to actually manage medical issues. A nurse is trained to manage nursing issues. A pharmacist has been trained to manage medicine issues. So why shouldn't the pharmacist actually have an opportunity to do that? So that's the question that I'd like to put to the audience and for you guys to consider from this point on, whether there's something that you can do in your sphere of practice to introduce medication management services. And that's the last slide. I've just given a few references, quite a few references, and I'm happy to provide a list of the references as well if you guys would like it at Alameen. Okay, thanks, and open for questions. I hope I've made some sense.
Thank you, ma'am. Thank you, Mrs. Geeta Pradeep, ma'am, for such a detailed, informative, and interesting topic. I'm sure all our participants have thoroughly enjoyed your topic. I would now request all the participants to pour in their questions in the chat box. One more request, all participants kindly fill in your feedback form before leaving the meeting. We would now proceed towards the question answer interactive session. Yep. For that, I would invite Dr. Vidya to take over the session, followed by the interactive session. After the interactive session, we will have the summarization of the topic for today. Over to you, Dr. Vidya.
Thank you, Dr. Tanushree. There were quite a few questions for you, Geeta ma'am.
Okay, that's fine. Happy to address them.
So actually, there was one professor, Dr. Jnanachandran, he would like to share some feedback about hospital and community. Sir, if you are available, could you be?
Yeah, very much. I am available, madam. I am Professor Dr. Gyan Chandran.
Yes.
Doing pharmacy studies for about 3 decades, like out of which
Okay.
about 15 years in Kingdom of Saudi Arabia with Ministry of Health.
Wow.
As a
Okay.
pharmacist supervisor. It is very excellent. I'm very happy. Initially, a little hesitation I joined, but on hearing Dr. Geeta Pradeep present, it was really wonderful, wonderful. She was telling something, just one point I want to highlight about the quality assurance of medicines. Since I was working in a hospital where I was controlling about 40 primary healthcare centers. Because this pharmacist and the pharmacy in the hospital, the pharmacist is the a very important role. The pharmacy should maintain all the medicines in a very good condition. And see, there are a few points. The premises should have good ventilation. The pharmacy premises, and it should have the adequate temperature. The normal temperature should be of the pharmacy room temperature has to be between 15 to 25 degrees Celsius. And you see, there is a chart also we have to mention every day. When you enter the pharmacy, what is the temperature? When you come out from the pharmacy, what is the temperature? So that we have to write it and we have to submit it and keep it. Okay, there will be a sort of quality assurance team will come and inquire. One thing, madam. And also refrigerator inside. If we keep some medicines like antibiotic, when vaccines, when about 48 degrees Celsius, and insulin should never be stored in the freezer. Insulin has to be stored in a low temperature, about 8 degrees Celsius, whereas polio vaccine has to be stored in the freezer. So these are the important messages. When the quality assurance and the inspectors they come, they verify all this. And then another one, just one or two things, madam. Prescription audit. Once a script, as you said, the script comes from a doctor, he has to, the pharmacist has to read the prescription from head to end. Tail. You should see what is the name of the patient, age of the patient, sex of the patient, what is the diagnosis, and what are the medicines. Then you should take all the medicine. Right medicine, we have to see what the right patient, and then give the right medicine to the right patient, call out the patient name, and as you rightly said, it is not just giving the medicine, we have to talk face to face. Because pharmacy is the terminal point where the patient is going out of the hospital. A pharmacist should have the competency level to talk to the patient and explain the medicine, what is the medicine given to him, how long he has to take, what is the frequency of medicine, what is the course of medicine. So all these things I was doing it initially, and subsequently I was supervising other pharmacists also. This is called patient dispensing and counseling. And every patient has got a file. When they come to hospital, the files they will take, they will go to the nurse for vital parameters measurement, and it will diagnosis done by the doctor, and it is written in the file. What are the diagnoses, what are the medicine they are given, and the doctor writes the prescription, and the prescription comes to the pharmacist. The pharmacist they check the prescription, take the medicines, and keep it. And about all the prescription, it is signed by doctors as well as at the time of dispensing, it will be signed by the pharmacist also. And one more thing, in the patient medical record department, if the patient is allergic to any medicine, they will write it. For example, allergic to penicillin.
We have what's known as an ADR
allergic
sticker.
to
So the ADR sticker goes on
they will
the
write it.
medication chart. And the pharmacist,
ADR sticker will be there.
The pharmacist actually look by looking at a purple color. Pharmacists in Australia, hospital pharmacists use a purple pen.
Yeah, thank you, madam. And one more thing, see, this is about the hospital pharmacy. And as you rightly said during your presentation, without a pharmacist, the pharmacist cannot be opened. Only pharmacy will open, he'll manage the pharmacy and close the pharmacy. Everything is under the control of pharmacists all over the world. Slowly it is coming to Indian level also. Let us hope things
Yes.
will change also. And
Yes.
medical shops in pharmacy, not like this in every 200-300 meters on a medical shop. No, there are limited medical shops, and every medical shop, any medical shop is given the 24-hour services. They will get permission from the government, and it will be open for 24 hours. And the message will be displayed in all medical shops and in the public places, and they will give in the TV also, television, social media. And on Sundays and holidays, any festival days, they will mention which are the medical shops are open on those days for getting medicines. And these are the free information, madam. Many more things I can spend due to shortage of time. It was very excellent presentation, Dr. Geeta Pradeep and Dr. Sobarani, madam. Thank you very much for giving me the opportunity. Thank you, madam, very much. Okay, we will come to you. And my dear students, whatever message given by Dr. Geeta Pradeep, please make a note of it and implement it. Your medicine is not something just like a grocery item, like it is a life-saving medicine. And our pharmacists are people, not only in dispensing, our pharmacists, they know they are the main healthcare specialists who are working in front of the farmer, in front of the patient, and as well as in research and development in the industry. So many areas they are working.
Yes.
So I wish you a very happy pharmacy profession, and I wish you a very prosperous growth for our Dr. Geeta Pradeep
Thank
and
you, sir.
Sobarani,
Thank you,
ma'am.
sir.
Thank you very much, madam. Thank you, madam. Thank you.
Geeta, I have a question.
Yes, ma'am.
I saw you mentioning TDM in the hospital setup. So is TDM common in every hospital, or is it like?
No, not in every hospital. TDM and even medication information services, ma'am, over the years, because the cost involved to set them up and to run them is quite substantial. TDMs are actually based in huge, tertiary care hospitals. So you might have, say, 1 or 2 hospitals. Unfortunately, most of the TDM centers are in the urban hospitals, are in the cities, not a lot of TDM centers in the rural places. And so earlier when I was working at UNE, for example, if something needed to be checked, you have to take the blood sample, it has to be sent to Sydney.
Okay.
So it will be flown to Sydney. They do the analysis. The information comes back. I mean, the information gets back via say the email or whatever, but not all. So even though it's a very specialized area, TDM. Same way, medicine information centers. Unfortunately, they were, I think, around the whole country has around 11 medicine information centers, and they're actually talking of closing, because they don't have, they're not able to get pharmacists to actually man medical information centers for in the hospital setup, because pharmacists are involved in other activities.
And
which is a sad
Geeta,
state of
do they also use our micromedics?
Sorry?
Do they also use micromedics or IBIS?
They micromedics, the hospitals might use it, but here they have what they actually use here is they have an Australian based meds index, it's called. And that's basically what they actually used. So there's one that's been developed in hospital, and what they have in hospitals is how can I say it? It's a central system that has subscription to a number of different databases, and that is shared between different hospitals. So that not one single hospital is actually spending the money, so that the cost is actually shared. That's how they try and work it out here.
Okay, thank you.
Ma'am, thank you, ma'am.
No problem.
Shall I move to the other question?
Yes, please.
Ma'am, there was a question. What are the steps that an overseas qualified, for example, he might have been graduated from India, the qualified pharmacist will have to take to practice as a registered clinical pharmacist abroad?
Okay.
What are the steps that he have to take?
Right. I was sort of expecting this question. Unfortunately, because there was no time to actually include that information, I didn't. Happy to give you that. When I'm saying abroad, I'm actually going to speak specifically about Australia. So if you remember the slide that I showed you, that lock and key model that actually showed a student as well as an overseas pharmacist, the path is pretty much the same. So in terms of internship, in terms of pharmacy qualifying exams after internship, it is the same for pharmacy students who have been educated here, as well as a foreign trained pharmacist. There are 2 steps that a foreign trained pharmacist has to do before they get to the same level as a Australian educated student. So the first thing is, now I'll take myself for an example. So I finished my pharmacy degree, I've got my transcript, etc., etc. First thing that I've got to do, if I want to practice, if I want to be registered to practice in Australia, is get my skills assessed. So there's a skills assessment, as it's called. So there is a pharmacy board. There is a pharmacy board of Australia, and the pharmacy board also has an advisory, what do you say? There's an advisory organization that's responsible for, it's called the Pharmacy Council. So the Pharmacy Council is responsible for maintaining registrations, giving accreditation to courses, universities that provide pharmacy courses, as well as conducting the intern exams, both for foreign trained as well as Australian students. So these skills, my skills, and there's a whole set of documents that you have to provide, that will be assessed by officers in this agency, and they will decide whether my education, my experience is considered eligible to start the registration process in Australia. So that's step 1. So that's skills assessment, right? And so once skills assessment is over, they will actually let you know, and it takes, they say 4 to 6 weeks, but it sometimes takes beyond that. Once that is done, they will let you know that, okay, fine, we have assessed your skills. It is found, you're eligible to go ahead and start the registration process. You can go ahead and apply to sit the first exam. The first exam is called the Knowledge and Assessment of Pharmaceutical Sciences, CAPS exam. Okay, so that 2 papers, which actually looks at pharmacology, pharmaceutics, pathology, pharmaceutical chemistry, therapeutics, divided into 2 papers. So you have to get, if I remember right, if you have to get 60% in each section. Each paper has got 2 sections, and in each section you have to get 60% to be considered a pass. That means you've crossed the CAPS, you've crossed that hurdle. From that point onward, you will join the rest of the pharmacy students who have been educated in Australia. So once that is done, you are fine to go ahead and get your provisional registration, get onto your intern practice. Intern practice is for 1,824 hours. You need to do 30% of that. You can appear for the first exam, which is a written exam. So sort of like your jurisprudence exam, that is, you can take certain books into that exam. The CAPS exam, you can't take any books, completely closed book. Okay, so that's the first equivalency exam, which is similar to the FPGE in the US, I think. That's our CAPS in Australia. So then finish your internship, 30% over, do your written exam, 70% of internship over, sit for your orals. And a lot of the students, even students who have actually studied here, the orals is what gets them, because that is all about therapeutics, providing service, etc. So that is the point which can be a bit difficult to get through. So once that is done, you can go ahead and register as a pharmacist and practice. There isn't any special sort of a pathway for a clinical pharmacist. You only have to get a job as a clinical pharmacist, and that's it. Hope that's answered your question. There is cost involved with all of this, and it's not a cheap process, let me tell you. It is fairly expensive. So for each step, you will need to actually pay the amount, right from skills assessment, CAPS, to each of the other steps. I don't know the amount from the top of my head. I believe CAPS should be somewhere around $2,000 for one sitting. And the rest, I really don't know. I'll have to look that up. But I'm happy to give my email if there's any questions, ma'am. If you're okay with that, they can ask you the question and I can provide the answers. I'm happy to do that, ma'am.
Yes. And I got a request that they need your presentation. So you can share the presentation.
I'll send it.
Yeah.
Thank you, ma'am. There is one more question. Scope of MPharm pharmacy practice in Australia.
Okay, scope. Now that's an interesting question. rather than look at it as a scope of MPharm pharmacy practice, see, there's a scope for pharmacy in Australia. Let's call it that. For registration in Australia, you don't need to be a postgraduate person, because the registration, the minimum qualification for registration in Australia is a 4-year degree course, right? So if you have a pharmacy course, if you've done your Bachelor of Pharmacy, provided your skills assessment, etc., goes well, you're fine to take up the registration exam. Where pharmacy practice gives you an edge is with the amount of clinical knowledge, the amount of, exactly what I've been talking about. That knowledge and those skills give you a slight edge, I think, compared, this is just my opinion, compared to, I suppose, your run-of-the-mill pharmacy undergraduate student in appearing for the exam. Both of you would have to get used to, you need to be able to know, I guess, you need to be able to know how pharmacy is practiced here. So as I said, I showed you this one book, right? This is a very important reference. There's another one, which is the Australian Pharmaceutical Formulary, APF. That is also a very important. So I suppose you could consider both those two books, those two references are probably the main books that will help you to a great extent in your first exam and as you get to your registration. In addition to other references, these are just two Australian references that I'd like to talk about. In terms of scope, like I said, it isn't having MPharm pharmacy practice gives you an edge in appearing for the exams, or maybe it will give you an edge in terms of appearing for the exams. But at the end of the day, there are no shortcuts. You have to do what you have to do. You have to go through the registration process as required, as every other foreign trained pharmacist is going through. There are two streams of registration. Some countries have, are considered to have equivalent education practices. So I think that's UK, Canada, USA, Great Britain, and South Africa, I think, are the 5 countries that have, reciprocal arrangement with Australia that, okay, fine, if an Australian wants to come and practice there, you're going to make it a little bit, you're going to make, they're going to have an advantage. Similarly, Australia's got that sort of an arrangement here. So for any of people who are registered in these countries, for them to come, there is another, a slightly more simpler pathway for registration. But for us from India, it is, I think it's called Path B or Path A, one of the two. Skills assessment, CAPS exam, provisional registration, internship hours, and the 2 exams after that.
Thanks, ma'am. And majority of the questions are oriented towards this migration to Australia only.
Okay.
What would be the best course, or do we need to write IELTS exam, or when would the applications, all those things are related completely towards that.
Okay, all right. So see, Australia, especially now in the COVID pandemic, in fact, they haven't had the first CAPS exams. This entire CAPS exams this year has been scrapped. It was supposed to happen, I think it happens 3 times a year, supposed to happen in March and then May. None of that happened because of COVID. They have decided to have it in December. That is the first CAPS exam. So I think the registration for that will open in October. So if anyone wants to write in December, you need to get your skates on and start the process now, because you need to get your skills registration done and the council to actually tell you you're eligible to sit for the CAPS by October, which is when the registration window opens for registering for the exam. It's not open for a long time. I'm not sure whether it is just a few days or maybe 1 week or something like that. I think it is open for a very short time. And then once the number of the seats are all taken up, it's closed. So that is one bit of information that I'd like to tell you. In terms of migration, see, until 2010, pharmacy was considered to be a skilled occupation. In the sense, Australia, the immigration department, the immigration department has got a list called the skills occupations list, right? And the skills occupations list basically lists all those professions that Australian government would like to have on board, would like people to come. Pharmacy was part of this list until 2010. pharmacy is no longer part of that list now. So that is, I suppose, one aspect that you need to consider, that pharmacy is no longer a skilled profession or skill. It's not on the SOL list or the skilled occupation list anymore. So that is one aspect. So then the next question is, so does that mean that there's no scope? No, there are actually people coming in and there are people being registering. So for those of you who are interested, I suppose one thing is to get your skills registration through, see if you are eligible, and at the same time consider, because Australia basically considers migration requests on a point basis. So you've got to look at, and what actually adds on to the point is not just your education, but also the years of experience. So say, for example, if you're a fresh graduate, you have a certain number of points. Again, I don't know the details of this. I think it is immi.gov.au is the site for immigration. That might, even if you just do a Google search, and you will get this information from that Google search about immigration information, about the SOL, the skilled occupation list. Generally, this past few years, because of the change in the government, there has been a move to try and reduce the number of migration. But having said that, in spite of that, there are still number of pharmacists who are coming, people who are coming in, able to finish their registration exams and are able to practice. So I don't know whether that's actually answered your question. Hopefully it's given you some idea, but yeah.
Thanks a lot, ma'am. Thanks for the patience. Thank you so
Okay.
much. Over to you, Tanushree.
Thank you, Mrs. Geeta Pradeep ma'am, and thank you, Dr. Vidya. I would like to propose the vote of thanks. I take this opportunity to give a big thank you and my deepest gratitude to our presenter today, Mrs. Geeta Pradeep, to our beloved principal ma'am, who has been our source and been always there for supporting us, to the management, and also to the coordinators who have arranged this meeting, that is Dr. Preeti Karwa, Mr. Rakesh Panda, and Dr. Vidya. Thank you, one and all. We have another lecture tomorrow, another international webinar tomorrow on the topic Transforming Local Health During a Pandemic, that is 16/9/2020. Tomorrow at around 2:30 to 4:30 we will have it. Till then, all of you all be safe and have a nice day. Thank you, one and all. Thank you, all of you.
Thank you, Geeta. Thank you.
Thank you,
Keep
ma'am.
in touch.
Anytime.
Thank you,
Very
ma'am.
happy to do this. Be safe, everyone.
Yes,
Thank you, ma'am.
thank you. Bye.
Bye.
Thank you.
Thank you, ma'am.
You're welcome. Shall I send the slides to ma'am? Shobha ma'am?
PPT. Yes. Yeah.
Okay. Is there
You
anything
can.
else that you would like for
Okay.
me to do? I'm happy to give my email as well.
Yeah, ma'am. Ma'am may be having the ma'am. You can communicate.
Communicate to? Sorry, I didn't get that.
Shobha ma'am, you can communicate to Shobha ma'am.
Yeah.
Your
Sure.
email and all, everything will get from her.
Yeah. Okay,
Oh.
fine. Yeah,
Okay,
done.
ma'am.
All right. Thank you.
Yeah. Thank
Bye.
you.
Bye, ma'am.
Bye, ma'am. Bye.